Welcome everyone to the third iteration of Borders and Migrations for fall 2021. Welcome to those of you both in person as well as those online. I'm happy to welcome to campus colleagues, friends, and former students, some of you across multiple of those categories. We have with us Elise Robinson here, who's the Director of Community Health at Neighborhood Health Center of Western New York, which she joined just last year. As a senior leader in community health and case management, providing direct oversight of the organization's community health team through a range of strategic outreach, community education, informal counseling, social support, and advocacy activities. Next to Elise is my friend and colleague, Mosko, PhD, who's the Grants and Development Manager for Neighborhood Health Center of Western New York, which she joined in 2021 to increase the health center's impact on health equity in Western New York. She works with federal, state, and local funding sources to design and implement special projects and programs, most recently including bridging the digital divide, refugee health assessments, and a new line of vision care service for patients with diabetes. Then in the middle of the front table, we have Carra Stratton, who is the co-founder and immigrant resource and release coordinator at Justice for Migrant Families of Western New York. Stratton's job entails working with local and regional agencies to help people who are detained at the Buffalo Federal Detention Center in Batavia to get them a home or place of safety after their release. She also works to support those who have been released and connect people with different community and regional resources, including mental health services, to help them during their immigration proceedings. I would just add that Justice for Migrant Families is one of the partners of Canisius for service learning with our Spanish classes. Next to Carra's right is Holly Maloney, a registered nurse who's also on the board of directors for Justice for Migrant Families and currently works in providing mental health care. And we'll speak about direct experiences. And then on the left of Carra is Francesa Velardi, DDS, who's a former student of mine, so Spanish minor. Who's the staff dentist at Jericho Road Community Health Center. Dr. Velardi is a 2016 Canisius grad, and then graduated from the University of Buffalo School of Dental Medicine in 2020, and completed an advanced education in general dentistry residency at the University of Alabama at Birmingham, and has worked as a staff dentist since 2021. And I would also say Francesca went to Costa Rica with me on one of our programs abroad where she did a dental internship, as I recall. Yes. Yep. So welcome to our guests, and thank you all for attending. The topic of this evening's conversation is providing healthcare to marginalized communities. And I think maybe we can start with Melissa and Elise to talk about their agency and the work that they do. And from the perspective of Borders and Migrations, I'm particularly interested in the work with refugee healthcare that you had mentioned, Melissa. So I'll let you talk, and then we will move on to Francesca and talk about her work, and then we will move to Carra and Holly, who will talk about their experiences, and then we can open it up for questions. So people watching online can send us your questions through the chat function, and we will ask them on your behalf, and those of you here can ask questions as well. We'll have that mic go live later. Okay. So thank you, Melissa.
All right, thank you everyone for being here and online, and thank you, Richard. It's good to be back at Canisius. So again, my name is Melissa Mosko. I am the Grants and Development Manager at Neighborhood Health Center, and I'll give you a high-level overview of the health center and our operations. Then I'll turn it over to Elise for a more in-depth introduction to the work of our community health team. So Neighborhood Health Center is the oldest and largest federally qualified health center in Western New York. We've been in operation since 1987, and we serve over 26,000 patients annually. We are kind of like a very big doctor's office. So we have integrated comprehensive care, which includes primary care, pediatrics, obstetrics and gynecology, dentistry, podiatry, behavioral health, nutrition, And now we have vision care. So this model of integrated primary care really meets our patients where they are. Our patients might struggle with access to care, might struggle with transportation, and so having everything in one place serves our population better. As a federally qualified health center, we serve anyone regardless of their ability to pay. Whether you have really high quality health insurance through your employer, or you're on Medicaid, or you're uninsured, we will see you. And we might charge you $1 for your visit, or we might charge you $1 for your prescription. But our goal is to increase access to healthcare in Western New York and to promote health equity for a population who have been historically excluded from healthcare. So our patient population is quite diverse, and our patient population also experiences excessive disease burden. What I mean by that is that in our patient populations, we see high rates of diabetes, high rates of hypertension, high rates of hyperlipidemia, like high cholesterol, high rates of obesity, high rates of low birth weight incident, and increased mortality, increased usage of emergency rooms and urgent cares. And so providing comprehensive primary preventative health care is our mission. About 85% of our patients are low income, that is 200%, at or below 200% of the federal poverty level. About 65 of our patients come from racially or ethnically diverse communities. And we serve patients in over 56 languages. We have locations in Black Rock, Lower West Side. We're opening one on the Upper West Side. We have a location in Blaisdell, location in the South Towns. So we are spread out around Western New York. So in my role, I've only been there a little bit, but one of my first projects is implementing the Refugee Health Program. And it's a contract that we have with the state of New York to provide health assessments for our newly arrived neighbors, to introduce them to the United States healthcare system, which is, in polite words, a mess, and inaccessible and expensive and confusing. We did a lot of training on how to provide appropriate healthcare for refugees coming from a variety of locations and experiencing a variety of traumas. We operate on a model of trauma-informed, resilience-oriented care, understanding that 75% of us out there have traumas that we bring with us every day. And so we apply that model to the Refugee Health Program. And I've had a lot of help implementing that from our community health team. They really, I guess, done the lion's share of the work on the ground, welcoming new refugees, walking them through the health center, getting them connected to specialists around Buffalo, and working with case managers to make that happen.
Thank you. Thank you again for inviting me. Again, my name is Elise Robinson, also with Neighborhood Health Center. I am the Director of Community Health, and my role is to oversee our Community Health Department. The community health workers, or CHWs as we call them, they are the ones that are on the ground, conducting outreach, in-reach with our patient population or the community. Their role touches on a number of things. So partly their role is to support our providers that are within Neighborhood Health Center and referrals that they make, and following up on either social supports, meaning they need assistance with housing, nutrition, transportation, could be language. So their role is to offer the support that way, and then and make those necessary linkages, whether it's in-house or out in the community. The other part of their role is to follow up on our initiatives. So we have a number of initiatives within Neighborhood Health, which we provide care through our Health in Motion, which is a collaboration with Buffalo Public Schools and the Say Yes program. And Planned Parenthood, it's a mobile unit that goes out to a few of the Buffalo Public School sites, and we provide care to those children, whether they're school age or adolescent. And it's to get them up to date with their immunizations, physicals, I'm trying to think, immunizations, physicals, just again, bringing the care to them that they need. And then also following up with those kids and their families with the social supports that they may need as well. But, you know, as things come up. We also provide care with the Refugee Health Assessment Program, which is a new initiative that we've implemented. And we have a community health worker that assists our provider. Their role is to make sure all the information that comes in from the CDC or the federal sites, that they get an assessment before coming into the country, of course, and then we follow up on what those needs are. And our community health workers usually are the ones that will welcome our patients in and assist them as they go through our process on site. So we try to make people or patients that come in feel invited, not feel lost by our system, you know, and welcomed. And we also know that language can be, we do assist a number of patients that English is not their first language. So we try to make them comfortable in that way. So we do use the language line. We do offer that. And we do have some providers that speak another language, or they may speak English as a second language. So that sometimes helps as well. We do a lot, so I'm trying to think. There's a list of things.
HCH maybe.
So, and then one of our largest initiatives is our healthcare for the homeless program, which we provide care to individuals that are labeled, I don't want to say labeled, but identified as homeless, whether they are living with a friend, living in a shelter, living on the street, couch surfing, whatever it may be. It could be a family, could be an individual. We do have a team that will go out to various programs, whether it's a city mission, Friends of the Night people, or other organizations that also help with homeless. We'll go out and we'll provide care to them. So if they're not coming to one of our facilities, we will go to them. But of course, as they come to our facility, we try to address, again, using trauma-informed resilience and meeting the patient where they're at. So if you're homeless, we're going to meet you where you're at. We understand housing may be your priority before you address your health care. However, as we're trying to link you with housing, because again, the community health workers will help with that as well, and doing the linkages with housing. We don't have a comprehensive housing program within, but we do work with community partners that do. So again, we are addressing your healthcare while trying to link you with housing, and we will follow a patient for up to a year after being stably housed. So we won't just house you and then, you know, you're on your own trying to get back to the provider or trying to get, you know, follow up on medical appointments. We'll be there to support you. Another initiative, so healthcare for the homeless, we have our mobile unit, which is our kids. We have a literacy program that's been implemented as well, and that's for school age children. Some of like I said, we do some in-reaching, but we also do outreaching. So our role also is to go out into the community and spread, you know, obviously COVID has kept us in-house. But the goal prior to COVID, and hopefully next year, we'll start to go back out into the community and share some of the information or some of what we do. And keep people informed that we are available and our services are open to anyone. So that's pretty much it in a nutshell. Thank you.
Francesca, do you want to talk about your experience?
Sure. So I'm Francesca. I'm a dentist. Can people hear? Are we good? Do I need to take a mic? Okay. Or not, okay. So I'm at Jericho Road. It's also an FQHC. So it was started by Dr. Glick. A lot of people are familiar with the Barton location on the west side. So I'm at the Broadway location on the east side. They also have clinics abroad as well. A group just was in Goma. So they do some pretty amazing work. So it's kind of started for the similar reasons to give care to individuals that either had no care or not really access to adequate care. So our populations that we deal with are mostly, refugee and immigrant populations as well. A lot of resources for them. We have translators in-house and we have a lot of things together. So I'm a dentist, so I'm on the second floor. We also have medical on the third floor. It's a really impressive building on Broadway. If you guys ever are around there, it's really cool. And they just built a gym with independent health to really give people access to some things that they either couldn't afford or just didn't have the ability to do so. Do you want me to talk a little bit about dentistry with this population?
What kind of problems maybe you encounter within that population? In terms of dentistry?
Yeah, sure. So dental care is a luxury, which we don't really think about. So access to care, especially with just state insurances, a lot of dentists in the area don't take it. So a lot of patients don't know where to go or don't have really the ability to get to some of these providers. So a lot of the patients that we have, as I said, are immigrant and refugees. So a lot of them have never been to a dentist before, which is really kind of crazy to think about. Luckily, we have the medical team above us, so they really help us out with referring patients that need our care and also try to reiterate how important oral health is to total body health. As you were saying, diabetes is really prevalent in these populations, and there's, if you have periodontal disease and, gum disease and you're not controlled orally, that actually affects your glycemic control, which is a lot of, heart disease also has a link to the mouth as well. So we're really trying to educate these patients on how oral health care is really important to total body health. So sometimes it's challenging because when they've never seen a dentist before, it's hard for them to kind of like buy in that, this is what we need you to do to really get yourself on track, and people don't want teeth out, so it gets tricky. But it's been overall really great. A lot of the patients are so grateful for what we can do for them, especially because they, they're in pain and they've never been able to see anybody before. So I've really enjoyed my experience there, doing some really good work for people who've never had access to the services that we can do. So I'm glad to give back to the community as a Jesuit Canisius graduate. And I use my Spanish all the time, Richard.
Okay, I was going to ask you that.
All the time. I'm one of like 2 Spanish providers.
What is the impact of you speaking Spanish to the patients?
They really appreciate it. I had one person who was like almost in tears because he said he's always gone to providers and he just feels like there's always this disconnect because either the translators can't really get him right. And it means a lot that you're able to, do that for them. And also it makes you a little bit more vulnerable because I'm like, I'm a little rusty. So they really have enjoyed that. And I know it means a lot to them too.
Thank you, Francesca. Carra, as my colleague, you want to talk about what justice?
Should we use this one?
Yeah.
Okay.
Is it on?
Is this on?
No.
No. So my name is Carra. I'm the Immigrant Release and Resource Coordinator with Justice for Migrant Families. We are a very small nonprofit in Western New York, and we work with undocumented immigrants as well as all immigrants impacted by immigration enforcement. So we have many, many programs. We do direct support, advocacy, organizing at a statewide, local, and nationwide level. But what I'm going to focus on today is a few stories that revolve around our work with the Buffalo Federal Detention Facility. This past year and a half, since COVID, in all of this country, but very much so in the federal detention facility, COVID exposed the systemic inequalities, the the horrific challenges that people face. It made it very visible, things that have been going on for a long time. So we're going to just tell a couple of stories of things that the challenges we see before COVID, but really that this year and a half brought to light. The Buffalo Federal Detention Facility is immigrant detention facility. So there are asylum seekers, there are legal permanent residents, there are undocumented immigrants. There's a wide range of different people who are there for different reasons. It is a prison. It looks like a prison, it acts like a prison, it's a prison. Since March of 2020, there were two very big outbreaks of COVID at the facility that resulted in 2 lawsuits against the facility for inadequate medical care. There were not enough, there's not enough staff who are trained in caring for people there. And one of the things that came out during the suit is that the attorney for the facility said, well, you know, it's not our fault. The outbreak began because people are afraid of solitary confinement, which is where we put people who have COVID. So no one was reporting it. So that is the state of how things were going in the facility. People were in solitary confinement. They weren't receiving treatment. There were no masks there. They live in dorms, so it's not a lot of protection. On our end, what we do as community members is help people once they're released. We have a hotline and we do pen pal and book program inside, but we want to talk about what happens when people are released. So when people are released from the facility, they are dropped off at a gas station. They do not have money or adequate clothing. They do not have a phone. They do not have access to a phone. They do not have food. They don't know the language very often, and they don't know where they are because it's called the Buffalo Federal Detention Facility, but it's not in Buffalo. If it were not for a group of organized community members, things would be much, much worse than they are, and they're pretty bad. So there's the people who work at the gas station call me every day and say, here's a person, can you send volunteers there? During COVID, what we had to contend with is people being dropped off again without clothing, bus tickets, anywhere to go, and having to make the decision of, are we going to pay for bus tickets to send these people home to their families? Coming from a facility where they have likely been exposed to COVID. Like, this is a public health emergency. So we worked with community members where people offered up their houses for quarantine housing, and we could house those people. You know, this was before testing. This was in the beginning. We could house these people for 14 days and monitor their symptoms, do drop-offs of food so that they could eat, contact their families, get them phones, and then help them get home. This continues today. Yesterday, there were 3 people who were released, and it's a similar thing where, again, without community members coming, these people would not have any kind of care. Holly's going to talk a little bit. Because of the conditions inside the facility, many people went on hunger strike this year. There were a great number, something like 30 people were on hunger strike at another facility in New Jersey. And to break up that hunger strike, they transferred people. So all during COVID, they were transferring people all across the country all the time, which then increased the likelihood of outbreaks in all of the facilities. So a lot of the people who were on hunger strike in New Jersey ended up here in Batavia and continued to do hunger strikes. And Holly's going to talk a little bit about that experience.
So as a nurse, I'm currently working with eating disorders. So when they let me know about these kids on hunger strike, just, I think story works better. There was one young man who was released with absolutely no direction. And how long had he been on his hunger strike?
A few weeks at least.
I think it was over 30 days.
Yeah.
And his hunger strike was he could have some fruit and water, and that was it. And physiologically, there are a lot of things that happen in your body that change to respond to kind of protecting your organs and protecting your body that change slowly. But when you go on that long, the response of your enzymes and everything slows down. Your whole GI system slows down. And so with eating disorders, when someone begins to eat, they have to be hospitalized and watched, because refeeding syndrome is what happens when you just eat after you haven't eaten. And they let this young man go, weighing, I think it was a little over 100 pounds. They let him go, locked him up at this gas station. And literally the person at the gas station makes minimum wages and just decided that he would be this liaison for us. And so this young man, he was released, he's young, he went with his friends and had Subway. Well, he ended up in the emergency room. I won't give you the gory details of all that happened to him. But again, being a marginalized person, they released him. They didn't do the follow-up care, and refeeding syndrome can kill you. He could have easily died. There are so many things that happen in your physiological system when you don't eat. And so again, we, went in and set up a whole feeding regimen for him, what he should eat each day, how many calories, what kind of calories, checked on him like in the beginning a few times a day, doing blood pressures, making sure he had no swelling in his hands and feet, and just brought him through it. But literally, this is just one small scenario. There are hundreds of scenarios of kids that have not had the care that they need. And, that's, I won't go further because I won't stop.
I just want to say one more example of the kind of like community care and the challenges that people who don't have any status face. Like the refugee system has a different kind of services that they're eligible for, but some of the people who are released for asylum seekers, they're not allowed to work. They don't have access to many of the different kind of social services. Thankfully, Jericho Road exists and other good places. But one other challenge for working with people released from the detention facility is in people living with mental health, with mental illnesses. There, again, because people are just released without notice to their family, to their lawyers, or to anyone, we're saying a couple specific stories, and we're saying them because their cases are closed in the United States. So that kid is fine now. He's safe and good. And the person I'm going to speak about right now was in a situation in which he could not be deported because the country they were trying to deport him to was not accepting people who were being deported. And he could no longer stay at the facility because he had stayed there for so long. And people were fighting for him to get out. So he was not eligible for any social services except for emergency Medicaid. Medicaid is not Medicare, Medicaid. Mm-hmm. Yeah, that was the only thing. So while we were working with his lawyers and his social worker for the Volunteer Lawyer Project to try to come up with a plan of what to do when he's released, we could get him medical care. We could get him, Buffalo actually has some amazing mental health services. What we couldn't get him is a person with living with extreme mental illness where he could not take care of himself, and he had been incarcerated for over 22 years. We could not find him a place to stay, to receive that care, or to have someone to help him make sure he's taking his meds, or make sure he's getting food, or make sure he doesn't wander because he just was not able to navigate things in that way. So the kind of release plans that we were trying to come up with were like, we should pack him a bag full of things because he's probably going to be homeless. And then, you know, like they're just without housing, without stable housing or a place for him to go. And, you know, there are amazing places like Vive around, but for people who are living with mental illness, there's not good long-term care for people, for immigrants without status, who are aging or infirm and or have disabilities. There's no really good long-term care facility. So we worked for a long time trying to find housing for a person who has a wheelchair, and there's just not accessible places for people without status. So those are all our challenges. Those are some of our challenges. Thank you.
Thank you, Kara and Holly. For those watching online, you can submit questions through the chat, and if people in the audience have questions, we can turn that mic on for you as well. I have a couple of questions to get things going. You mentioned, Melissa and Elise, that you deal with 56 languages. How? And this is of interest to me as a language teacher with not enough students. So.
Yeah, so we have the capacity to serve patients, and I don't know what the actual capacity is, but we do over 50. Our one way we do this is with really intentional recruitment. So we try to hire people from within the communities that we operate. And so we have a lot of frontline workers who are dual English and Spanish speakers, because Spanish is other than English, the second most popular language that our patients speak. And then we have a couple of providers who could speak Arabic. That's the second largest population of outside of Spanish speakers that we have. But for anything other than that, we use a language line, so medical translation line. It is incredibly helpful and incredibly difficult and incredibly clunky, and can be very depersonalized. So we would call in, we would ask for specific language. So for instance, we had our first two refugee patients were from Uganda. They spoke Swahili. And so we got a Swahili speaker who was trained in medical translation, and our community health worker spoke through the phone to the patient. The front desk person spoke through the phone to the patient. But one of the things that we also encountered in that first visit was how things get lost in translation, how many euphemisms we use to describe very basic functioning in a doctor's office. And I'm not going to tell you, I'm not going to get into what it was, but it can be very difficult. Yeah, but language line medical translation. I think that if you're looking for your next niche in academia, I think that language for the medical professions is going to be where it's at in the next 10 to 15 years. So,
well, I'm proud to say that the program that Francesca participated in Costa Rica was designed around.
Yeah.
I mean, I think a lot of people think that you can just Google it, right, and get an answer. But those of us that work within these language communities know that it's also cultural presumptions about that, and also, as you say, you cannot translate idioms the way we think one can through. Another question I have is about funding issues. I mean, all of these things seem massive. That they're trying to address massive problems that require a lot of money. And so I'm wondering how the funding works for the different organizations and what you need funding-wise and how that works.
You all want to go first?
Okay. Oh,
Yeah.
funding. We are primarily volunteer run, so that helps. And yeah, in terms of funding, there's some grants because of the work we do is with populations that funders sometimes don't want to attach their name to, like there's the aura of incarceration around immigrant detention on purpose. So it's not like, hey, it's hard for like big funders to want to give money to us. So we rely on small grants and donations. Things that we need, like the work we do with releases is our second biggest expense after staffing. Last year alone, we spent over $12,000 just on bus tickets. So that doesn't sound like a lot, but that's a lot of our budget. Yeah, so all of that is just like raised from donations primarily.
I don't know a ton, but I can tell a little bit. So we have federal funding as well as we have people who are very generous. Vive is one of Jericho's ministries, and there's some people who just have, I mean, it's an incredible thing that they do. So I know we recently had someone donate, I don't know the value, but it's like the largest single donation that we've gotten to expand Vive. So they're going to be increasing the ability of individuals that can be there soon. We're on Amazon Smile. So you can put Jericho in there in some of your Amazon purchases, Richard. Will go to Jericho. Other than that, I know it's a little bit of private and public as well. I'm just a dentist, but from what I hear, that's how we get some of our funds. And my hard work.
Well, I was just working on the 2022 budget today. So, like, Jericho and Neighborhood Health are both federally qualified health centers, which means that the federal government through the Health Resources Services Administration provides what we call our base grants, right? Basic level kind of funding that funds our basic operations. And then at least for us, our biggest source of revenue is actually patient revenue. And that is the payout from insurance and Medicaid. Our number one insurance is Medicaid, of all the different stripes and varieties. So so a lot of our funding comes from there, but for anything over and above patient care, we have to seek federal, state, and local funding. So we have a couple capital grants coming in from the state for the facilities expansion. There was the only upside to the pandemic was that there was a lot of funding released from the federal government for health centers. So we've been able to do a lot with that. And then we have a number of private foundation grants as well. And then our supportive initiatives. Where does our money come for those, Elise?
All right, our supportive initiatives, like our Health in Motion program, again, that's funded through Buffalo Public Schools and Say Yes. Our Refugee Health Assessment program is funded through the state Department of Health. The community health workers also rally and with, like I said, doing outreach and reach within the organization where we have set up funds that the employees donate every week. So there's a weekly fund or collection that we take. You get to wear jeans, so it's our Jeans Day fund, we call it. But those monies are used to give back to our patients and the community, and so it's a collaborative effort with our employees.
Because of the relationship like Fidelis.
Yes, I was gonna say, and then some of our insurance companies, of course, we have, they like to collaborate. I was trying to think what other initiatives we do. They like to collaborate with us in some of the initiatives that we have going on, especially when we are doing something that's giving back to our patients. So, and they're pretty generous, whatever we have asked for, they have collaborated with us, whether it's hats and gloves or monetary donations. Cell phones.
Yeah.
So we do have the Digital Divide program, which has helped us increase our telehealth visits within neighborhood health centers. So they've allowed, they have supported us in giving us funding to purchase cell phones and give those to patients that don't have adequate technology to link or access a telehealth visit. So our community health workers will help go through how to navigate through the phone and connect digitally. Even taking it a step further, there's funding to give them access to the SIM cards to actually have minutes for the phones. I'm trying to think, there's other things I'm sure I'm missing, but there's a wide range of where we get support from.
We have a couple of questions coming in from the online viewers. One is, does any facility or any of your organizations do free health events for the community? And if so, how can people get involved to volunteer at these events? This is coming from a person in the Canisius PA program.
So I'll go first, since we just did, today was Project Homeless Connect. And this usually is a large event in Buffalo where it previously was held at the Buffalo Convention Center. And it's a number of vendors that will come in and serve our homeless community and sometimes make instant linkages right there because it's, you know, it's for them, it promotes services for them. So whether you're, like I said, deemed homeless or just in transition, it's a great opportunity to link with organizations that you probably weren't aware of. That's usually a great opportunity to do some volunteering. As far as within our organization volunteering, I can't say that we have opened up to anyone outside to do any volunteering, but hopefully in the next year, we can do that. Usually we ask employees to do the volunteering, but we have used AmeriCorps in the past, but and some interns as well. So like I said, right now, a lot of that has been on hold, but I would be the one you would reach out to if you wanted to do that. So I am looking to do some of that for next year.
Thank you. And I think when we do post the video, we put their contact information in there. Did any of you want to talk about volunteer opportunities?
I know it's been a little tricky with COVID, because I think if people want to come, even we had someone come shadow and they had to go through like the whole HR process. So I think they're really trying to limit just within, you know, the services like medical, dental. It's a little tricky to get in there, but I'm not 100% sure if there's any volunteer opportunities at the moment.
We have a ton of volunteer opportunities, but very few that involve like actual healthcare, unless you want to be like Holly and get called in the middle of the night to come take the pulse of someone on hunger strike, in which case, let me know. Very useful, but yeah, we have a pen pal program. We have a phone line that is staffed 6 days a week for people who are detained to call. We have send a book to someone who's detained. We have, if you want to organize in the streets, like anything that you want to do, let me know and I can find you stuff to do.
Just a little plug. Our students at Canisius do a lot of volunteering. In fact, my bud guru here tonight did the phone line last night. Yeah.
Thank you.
Another question from the director of the PA program here at Canisius. As the PA program here at Canisius, we are heavily focused on addressing health disparities. What are some tips you can offer incoming health providers about resource management or partnering with agencies like yours, even if not in this area when they graduate? What are some general considerations you need us to understand in order to train them properly to care for these populations?
So I guess the way I'm gonna answer this is just based on my experience. And because I've been in community health for about 18 years. Besides my youthful look, I've been I've been in the community for doing community work for about 18 years. And I think I've seen different levels with providers. I've seen some providers who have been in community health and have a better understanding of like disparities and social determinants of health. And then I've also seen providers where they're a little disconnected because they may be only serving populations that have private insurance and not a whole lot with Medicaid. However, what I would suggest is that do some research, just like we talk about with anything else, whether it's understanding what social determinants of health actually means, or breaking barriers, diversity, inclusion. You have to do your research, you have to study on these things, or have a conversation with people. Take some time to like either volunteer or expand some of the work that you do. So take some time to either volunteer or get an opportunity to observe like low income areas, just so you can just get a better sense, a better idea of what healthcare really is for a wide range of individuals and patients, because it's not the same for everyone. And there's so many, like as she said, or as all of you have said, our healthcare system is pretty broken, and COVID has definitely pulled the Band-Aid off of how we do healthcare here. And there's a lot of work that still needs to be done. So I hope that answered part of the question.
Any other tips or suggestions?
I would say from a pedagogical standpoint, an understanding of trauma and the effects of trauma, the real systemic effects of trauma on individuals and communities, and intergenerational trauma. I know those are heavy things and we might not have time for those in a curriculum, but I think they're necessary for any provider, be it an MD, a DO, an advanced practitioner, a nurse, to I think meet patients where they are. That, you know, the reason a patient might always be 20 minutes late for their appointment is because they've been on survival mode for 30 years and their executive function just doesn't work the way that others does. Understanding those sorts of things is really important, I think, to providing healthcare and bridging towards health equity. I would also encourage anyone who's looking for work in the medical field, nursing. I don't know about advanced practice, but I know that for MDs and DOs and for dentists and nurses, if you work for a National Health Service Corps site, you can get some sweet loan forgiveness. So look into that. I know Jericho's one, we are one. And so if that's something you're really interested in, invested in, there are organizations out there that'll support you, and you don't have that as much of a burden. I'm not going to say it's no burden, but as much of a burden if you choose to work for those sorts of organizations.
I can say one little thing. I think especially with medical training, you spend 3+4 years, depending on your program, on how to be a clinician and how to be a doctor. They don't teach you empathy, cultural awareness, or anything like that. So I think it's really important, kind of as you were saying, we don't really have an insight to what people are going through. Like some of these people are like fighting to survive, and we're like, what do you mean you don't brush your teeth? Maybe they never had a toothbrush. They probably don't even have a place to sleep. You don't know where they're coming from. So I think that's a really important thing that needs to be focused more, is just to really understand the whole person and not just kind of zero in on something. You can be a good doctor and also be a good person and empathetic person, and treat person as a whole. I think that's really important.
How did you get so smart?
I had some really great professors at Oh, sorry.
Yeah. So I have to really reiterate what you had said. There's no way to learn better than to spend time with people that are in this position. But sometimes we have to step outside our community to really have eyes to see. And I believe Canisius has some programs that they go to other countries like Costa Rica, and really work with people and understand. Sometimes you just have to understand it from outside your community to come back and have open eyes for what you feel like in your own community, and then you can see it in your own community. But I think volunteering and walking with people who are marginalized, research, understanding trauma is huge. And how many people, the percentage of people that have experienced trauma is, I don't know what the latest numbers were, but they were well over 50% of the people that we've tested.
Did you want to add?
No.
Do you have any questions from our in-person audience? Yeah. Is that mic needs to be turned on? But
for these communities, what has your experience been as far as like distrust in the American medical system? I know that's a big thing for current and historical reasons. What has your experience been with that, and how have you kind of dealt with that?
Everyone's looking at me. I think, well, I can just tell you my dental perspective. I think in any area of patient care, compliance is always an issue. Dental, I think, is even harder because a lot of people have infection, but no pain, no swelling. Don't worry about it. I don't care. It's not like someone has their hand cut off and they're like, oh, look, this is gangrene. That's what's going on, but people won't address it unless there's pain. I just think a lot of people who haven't, sought care in a long time, and then here they are coming to me and I'm saying, hey, I have to take all your teeth out. That doesn't normally bode well. A lot of people are in denial about treatment. I think I can't say a lot about medical distrust. I think a lot of people just don't have the education. Unlike WebMD, a lot of people can't Google dentistry because dental treatment is very different based on practitioner and just case by case basis. So I think it's a little bit difficult in that aspect, but I just think overall compliance for any profession is a little bit tricky because patients are always going to want to do what they want to do. Autonomy is a good thing sometimes.
So for me, some of my experience has been, I worked previously as a case manager years ago, and part of my job was to, of course, make sure that the patients that I was working with, especially at the time I was working with people who were HIV positive. So it's a very, widespread community, different walks of life. And part of that was to try to convince them that they need to, see their provider regularly, of course. And working with different communities, so, sometimes you're dealing with someone who may feel like the doctors always have something bad to say, so why should I even go? But not understanding that it's preventive care. And, you going will help prevent something else happening. Then there's, I worked with women and children, and you have mothers or different ages, various ages, and you have young mothers that may not know any better, don't understand prenatal care, not just for them, but it's for the baby, or just, no support in their pregnancy. So why should I go to the doctor when I have to figure out where I'm going to stay because I'm being kicked out of my house, or I'm in a violent relationship? So that's not the priority. So even now with neighborhood health and the community health workers, sometimes they run into some of those things. And how do we support our patients to get them to see the bigger picture and provide, meeting them where they're at and providing care, getting them the care that they need. So sometimes you do run into that. But you just, again, the important part of that is meeting the patient where they're at to understand why. what's keeping them from attending those appointments or making them feel the way they feel about going to the doctor. Why are they afraid to go to the doctor? And if you can get to the why, you can understand better how to help them.
This is kind of maybe anecdotal, but it's about 3 weeks ago, I was in a meeting and we were talking about COVID vaccination rates. And we look at our COVID testing and our COVID vaccination rates broken down by race and ethnicity. And we compare that against the county average, county averages. And we were talking about, this was 1 week, we had this, an increase in our Hispanic and Latino populations coming in and scheduling their COVID vaccines. And the reason is we had, for our in-reaching to our Hispanic patients, we had one of our Spanish speaking staff members call them. How simple, right? And that's an example, I think, of meeting people where they're at, right? I think the other piece of that is health literacy. 1 in 3 people in New York State does not have a high school diploma or GED level education. And that level of basic literacy kind of, has an effect on a person's health literacy. So this is something that I've only been on the job for 9 months and I'm coming from an academic background. And so I'm learning on the job to take the words that I use and the language that I speak and to make that and to translate that for people to better understand in clear and simple terms what hyperlipidemia is and how you get it, or what a diabetic eye exam is and why you need one. I can explain that at a high level, but creating signage, documentation, handouts that reflect your patient's language, reflect their cultural assumptions, and reflect on multiple literacy levels. I think are kind of more some strategic tactics to address health literacy.
Everything that they said. I experience that often around mental health. The thing about meeting people where they're at and then understanding the need for translation, both in terms of language and cultural assumptions. It looks very, very different in different cultures, what mental health is and how you take care of yourself in those kinds of ways, the kind of services you would need and why. And then the other thing in terms of distrust is the people we work with, because they are undocumented, if they have not been yet impacted by immigration enforcement, they're very scared of seeking any medical care. They don't know who is going to turn them in. So often they do not seek medical care. Their children, they don't have their children seek medical care. And then for people coming out of detention, if their medical care entailed like, oh, you have COVID, go to solitary confinement, they are very wary of medical advice and health practitioners afterwards. And one of the things people ask a lot is like, I ask if they've been vaccinated in the facility and they say, yes, but I don't think it was the vaccine, and they want to get another vaccine because of that. So they just don't trust anything that's been given them.
So another question is, we're in the middle of a local election. We've had a change in the governorship, surprisingly, and midterms are coming up. Things are hanging in the balance. I guess I wonder what you feel the political climate is in terms of changing some of the systems that your organizations are trying to ameliorate. Because it was a great big hope for the last election. Any thoughts you want to share on that?
Well, I just read the America Builds Better Back, whatever that was called today, and all of the things that were gonna be in there aren't in there. So there's that. It's a strange climate, strange political climate. There's a generational shift in the attitude towards universal health care. I think the tide is going to turn that way. But I don't think it's going to happen now, right? I think it would make a lot of our jobs easier if healthcare and dental care, right? Because for some reason, you know, jawbones and teeth aren't essential to a person's livelihood according to a lot of our insurance payers. Or your eyes, right? Your eyes too. If it was more accessible and more affordable. And the amount of money spent on the insurance industry, that if that money could go towards patient care and access, we wouldn't have a lot of these issues. We are, you know, in terms of our refugee health program, I think that we're in a good place in New York State and federally with that. Recently, Biden did sign an executive order that the humanitarian parolees from Afghanistan will be eligible for refugee health assessments. So I think that is good as well. We are looking to bring about, I think, 1,600 refugees to the Buffalo area this year. I think it's only us and Jericho Road right now that are doing refugee health assessments. So it's going to be a few patients. And I think both of our organizations are primed and ready to take those patients on as, you know, for primary care as well. I can't speak to the other immigration things.
Anyone else want to weigh in on political fraught water that we are from?
I feel like I would get into dangerous territory.
I forgot I don't have the anymore.
Tread lightly.
Um,
Right.
Melissa, you mentioned the status designation for Afghan refugees and their ability to thus qualify for certain care. This is also from an administration that is continuing to enforce Title 42 and using health as a border, essentially. I don't think Americans know what this is about, but I think it's curious that we can give with one hand and take away with another all around issues of health and who has earned it. And I think we as a society maybe ought to contemplate that a little bit. Do we have other questions from the audience, either online or in person? I'd like to sort of close out these discussions with two questions. They're related. One is, what motivates you to do this work? Because it is challenging and difficult. And the other question is, given the often challenging nature of this work, how do you take care of yourself to keep doing it?
That was very trauma-informed, resilience-oriented. We recognize the trauma and we emphasize the strengths that we have in meeting those challenges.
I've had good friends to teach me those things.
My boss just asked me this question, so I'm primed for my answer. The reason why I'm drawn to healthcare and accessible healthcare is because when I was 27 years old and in graduate school, I was getting my PhD in philosophy at Marquette University. Go Jesuits. Right? I didn't have health insurance. This was before, no, I did have health insurance. This was before the Affordable Care Act, or otherwise known as Obamacare. And so there were no regulations on the kind of health insurance policies you could sell someone. And so I don't know how much money I spent that year on health insurance, but it basically didn't cover anything. And I was a young, healthy 27-year-old. And one day I couldn't walk down the block. I couldn't walk upstairs. And every time I tried to stand up, I had chest pain. And I knew how much it cost to go to the doctor, so I didn't go. I wound up at 27 years old having emergency heart surgery because I had a viral infection that went to my heart, and I could have died. And if it wasn't for a community health worker that my mom asked for when I was in the cardiac ICU, who set me up with a social worker, who set me up with a financial planner, I would have left that hospital. I did leave that hospital with $100,000 worth of debt. And the hospital ended up forgiving that debt because I was a poor graduate student with no assets to my name. But I was lucky, number one, that I survived. And number two, that my mom had the wisdom to ask, to know that I was going to be leaving with that kind of bill and to know that there were systems in place. And a lot of people don't have those luxuries. And so I write grants and I implement programs because I want people to have access to care, and I don't want people to be afraid of accessing that care because it's going to cost too much. And I take naps. That's how I take care of myself.
Yeah.
She also has a 3-year-old toddler. So
I do have a 3-year-old toddler. He's very cute. I take naps, and one of my good friends at work and I schedule lunch on each other's calendars, so we have to leave our computers. That's what I do.
Why do I do this?
You've been in it for longer. You need a why.
Same thing, my supervisor asked me the same thing, like what makes me show up every day? And one, I choose to do it. And I choose to be happy in doing it. I don't look at it as I am helping anyone, but I'm informing you what's available. I do, there is help there in giving someone the tools that they need to have a better day. I think it's always been rewarding to me when I make someone else's day a little bit easier. And I have heard that before. So that has been rewarding to me. That like I said, I've done a number of things in community health. And I remember a woman telling me, I applied her for insurance. And she said, she just said, "You're an angel. I thank you so much. Don't tell me it's your job, but why are you doing this?" I said, "Well, it is my job. But I'm glad I made your day, and I'm glad I made you, happy today. And I'm glad I was able to link you with insurance, and now you can get the care that you need." I've, placed people in housing, help them with housing. So stuff like that, it's rewarding when you make someone else's day a little bit easier that they can get up the next day. And I don't look at it as a job. I really do enjoy what I do. I really do appreciate the patients or the people that I work with. I love, I'm not afraid to just talk to anyone. I think that's the biggest thing too. I'm not afraid to talk to anyone. Even when we can't speak the same language, I'm like, I'll slow down and try to understand you, and you try to understand me. And, like I said, that puts a smile on their face, and it helps them, but it also helps me. What do I do for myself? I take time. I listen to myself. I listen to my body. I'm getting older. I don't hang out like I used to, but when I do, I enjoy it. I'm probably in bed before 10 every night. That's my self-care. Get rest, take time for myself. Even if I sit and watch Netflix all day Saturday, that's my time to not think about anything. It's brainless work. I just watch TV and enjoy the moment. Thank you.
Thank you for your answers. Carra, do you want to?
Yeah, sure. So what motivates me? I think our relationships are the people I have met, the people I get to work with, the people I get to talk to. It's like this woman we had been visiting since 2018, getting released this year. And now she lives down the street, and I get to like text her about clothes and stuff, and what she's doing that day, like being able to see people, like being able to attend a wedding of people who were detained a couple years ago, and then now got granted asylum and got married and are setting up their home. Like those triumphs feel so huge. Like when the base level is devastation, those triumphs can really just change. They're life changing. And what I do to take care of myself, lots of rest, lots of naps. I turn off my phone, and I also work with people where we take care of each other. And I think that's really, like, we look out for, I was talking to Holly about this, but we all look out for each other and do things like make sure we're not in front of the computer all day, take walks. Are you getting enough rest? What do you need? How do we support one another in this work too is really important.
So I think what everyone has said is what has always motivated me is that connection, that human connection. I think that finding a way to open yourself up to really connect with people shifts in something inside of you. And I think that for me, it happened after the Vietnam War. There were all those refugees then that were boat people that were coming, and people around me were all saying they're stealing jobs. And I had the opportunity to go to a refugee camp in Singapore and hear people's stories and connect with them. And that changed my life forever. It was just what you experience every day. It was life-changing. And so it brings me joy to connect with people. And for self-care, I do a lot of yoga, and I have a 10-month-old grandbaby that is my joy.
Yes, I'll go last. So what kind of keeps me going? I always viewed my dental education as a gift that I could give back to the community to serve, just because education is a privilege, not a right, especially higher education. So I think everyone has the right to choose how they want to use their education. A lot of my friends are in private practice, and they ask me every day, like, how do you do this? Because it's not easy. I don't think any community healthcare work is easy. Like anything in healthcare, the patients are the best and worst part of your day, depending on the patient. I just love that I can help people. You can give someone a smile that hasn't had one in years. If patients are in pain, you are their hero, if you can get them out of it. So a lot of instant gratification for dentistry, and just being able to provide that for patients. They really appreciate what you can do for them, a lot of them, because they haven't had access to healthcare, especially dental care. So they really value what I can do for them, and it's really rewarding. What do I do for self-care? I really need to get a chiropractor, and massages, Netflix, glass of wine here or there. Yeah.
All of it.
Well, thank you all for the work that you do and for enlightening our audience, both in person and online, about the work that you do and opportunities to perhaps learn more and support your organizations. I want to thank you for accepting my invitation to come here in person in the middle of a strange ongoing year of strangeness. Thank you all for coming, both online and in person. So Yeah, thank you.
Thank you.
Thank you.